Today, I'm going to talk about how in Karnataka, India, in our program, which has been implemented by Karnataka Health Promotion Trust, we tried to understand the diverse needs of the sex workers and through the program cycle, basically try to address these needs and how the program generally evolved over a period of time. This is a around 9-year-old program, and we are in the ninth year. My presentation has actually 3 parts. The first part talks about the evolution of the program. The second part talks about some of the indicators of success and some of the results. And the third part talks about where we are today and the specific needs that we are addressing today in the context of our partnership with the STRIVE project. The program that I'm talking about is funded by the Bill and Melinda Gates Foundation under the Avahan India AIDS Initiative. It has 2 phases. The first phase was from 2003 to 8, and the second phase is continuing from 9 to 2013. The first phase largely focused on scaling up the intervention in the state, and the second phase focused on consolidation of the results and handing over the programs to the community-based organizations and transition to the government. As I'm speaking, all our programs are transitioning to the government funding, and we are now supporting the government to manage these programs better. The project covered 19 underserved districts which had high prevalence but very less or no programs at all, covering 127 cities and around more than 1,000 villages. And it reached around 60,000 sex workers, female sex workers, and 20,000 MSM. When we started off, the project objectives were very clearly the standard objectives of increasing condom use and reducing STI. My talk largely focuses on the female sex workers part, so I'm trying to concentrate on that from now. We did have a program with MSMs also, but I'm not talking about it in our talk today. The objectives, the project strategies to achieve these objectives were largely defined as mapping and assessment, peer education and outreach, establishment of STI clinics, either within the drop-in centers or referral to government clinics. There was an element of empowerment of sex workers and creating an enabling environment, and also building capacity of the partners. And as part of the design consideration that we made was that we said the project would be evidence-based. There would be standardized core components, but of course will remain flexible depending on the needs of the community and needs of the geographies. There would be simultaneous and pilot and rapid scale-up. We wouldn't do pilot projects, but we would actually work in 19 districts at the same time. Use a proven package of services. If there is enough evidence that peer education works, we should not reinvent the wheel. We would use those packages which are proven. It would be oriented towards listening to the community and addressing community needs. And there would be a continuous gap analysis and reflection and a problem-solving process that would be inbuilt in the program. Throughout the project, we said we would like to be a thinking and a listening program, which would mean that we would like to look at our evidence very carefully and think through why we are not achieving certain things. And we would keep our ears on the ground so that our program is also guided by what the community tells us and not only what data we are collecting. In the first few years, we had a very rapid scale-up. As I said, we scaled up to the 19 districts at a go with partnership with NGOs and CBOs. We hired a huge number of peers. We set up many drop-in centers, set up clinics which were either static or in outreach clinics, and distributed condoms. And these were largely our focus of intervention in the first few years of scale-up. Though we had an objective of enabling environment and community ownership, we didn't do much during that time. But what we did was actually did a lot of community consultations. We used drawing, storytelling to look at, talk to community about what the issues were. And clearly health was not so much of a big issue for them, but there was issues of police violence, stigma and discrimination. Communities were unaware of their rights and entitlements. They were very much very fatalistic. They didn't know what to do about all the violence that was existed. And they had very low self-esteem. And these are voices that we heard consistently from different consultations that we did from in different parts of the state. At the same time, we had data that came in from our first IBBA, which we did, and Interestingly, it did show that there was linkage between violence and HIV. We found that sex workers who experienced violence visited clinic less, they had lower condom use, they had higher incidence of condom breakage and high prevalence of gonorrhea. We also found that sex workers who experienced violence also consumed more alcohol, and that gave us very strong impetus to work on issues of violence, which are not only community needs, but now even evidence is showing that there is a strong linkage to the objectives that we are trying to meet. And we re-strategized, and we had a three-pronged strategy to enhance our enabling environment. The strategy included reduction in stigma and discrimination, reduction in violence and harassment, improving social equity. In the context of violence and harassment, we did a lot of training and capacity building for sex workers on their rights, on their entitlements. We did, again, a lot of sensitization of the police involving the sex workers community on use of violence, and does the law allow use of violence. We helped the community members to set up a 24-hour crisis management system. Whenever there was an incident of violence, there was a telephone number that the sex workers could call to, and there would be support in whatever form or shape that would be available to the sex workers. In terms of reducing stigma and discrimination, a lot of work was also done with media to present positive stories of sex workers, how sex workers are peer educators, how sex workers are have formed CBOs and are actually doing their bit for HIV prevention. Improving social equity, we did a lot of advocacy with the policymakers to make sure that sex workers can access their rights, whether it is an identity card, whether it is voters list, or even housing facility. All of that basically gained momentum based on all the consultations and the evidence that came in. And around the same time, we also focused quite a bit and gave a bit of our energy in increasing community participation across the project cycle, involving community members initially in mapping, and any research that we did, we made sure that they would be community investigators in that. Involving community members in peer selection, identifying their issues that are important, developing project strategies, identifying spaces for drop-in centers or clinics, even during implementations, monitoring those activities that the project was doing. We had committees for clinics, we had committees for legal action, and did campaigns, and looked at also developing institutions of the community through CBO formation. Part of the community mobilization process was actually building solidarity among the sex workers, creating spaces where sex workers could meet and discuss issues through a reflective process, issues of gender, issues of sex work good or bad, self-esteem issues, and then facilitating collective action where women could actually come together and get into the habit of solving issues together, whether it is the issue of crisis, whether it is the issue of managing a process or managing committees, and then facilitating formation of community-based organization. So as we speak, today in Karnataka, 70% of our interventions are actually managed by community-based organizations, which were earlier managed by NGOs, and now they are receiving government funding through the process of transition to government funding in Avahan Phase 2. I'm going to share a little bit about our evidence of success through this whole process of mobilization, a community-centric process. We did see a huge amount of gain in the project. We are measuring most of our success through IBBAs that we did. We have done 3 rounds of IBBAs. We have also done annual outcome surveys through polling booth method, and also done behavioral tracking surveys. So the data comes from different sources, but this data, especially on program exposure, comes from IBBA round 1 and round 3, where we saw that there's a huge increase in sex worker being met by a peer educator, or sex worker visiting a drop-in center or a clinic, or even watching or witnessing a condom demonstration. We saw increase in condom use with different partners at last Sex Act, or even last month with a commercial partner. We did also see some increase in condom use with a regular partner, but it was not very significant, and I'm going to come to that later. We saw reduction in HIV and STI among sex workers if you compare the data between round 1 and round 3, and some of it is quite significant. What was interesting is that we also measured some of the community mobilization work and the violence work that we have done. And then this slide, we see that through the PBS, polling booth surveys, annual surveys that we have done, we found that FSW who have reported being beaten or raped in the past 1 year has reduced considerably. And sex workers who have had exposure to the program experience less violence. Of course, we have grown smarter since then, and our indicators and measurement questions have improved over time. But because the consistent question was being beaten or raped, and that's what I'm using here. There has been reduction in arrests and also alcohol use, interestingly. Though we didn't have, except in Bangalore, we didn't have a big program on alcohol de-addiction, but we do see that there is a decrease in alcohol use over the period of project. We also made good progress in community mobilization. There were 11 CBOs who were registered in 2007, and today there are 37 FSW CBOs and 15 MSM CBOs, which have huge number of membership. Membership has increased considerably, and they also have a huge number of corporates. And as I mentioned earlier, most of the CBOs are actually implementing programs with government funding today. In round 1, 2, and 3, we see increase in membership in self-help groups and also increase in membership in CBOs, costs to some extent suggesting the value in being members of a group. We did analysis to find out, especially with the IBBA data, to find out if there is any linkage between community mobilization and use of STI HIV services, and we found that there is significant linkage, and those who had high exposure to community mobilization did visit the clinic more often or take HIV tests. We also found that sex workers who are members in group actually experience less violence and less exploitation, I guess showing the value of being part of a group process. However, with all the successes, some challenges still remain. We have found that addressing issues of intimate partner violence and risk has been challenging. In the earlier slides, as I had mentioned, condom use with lovers or intimate partners, though had increased to some extent, did not increase significantly. We are also finding it very challenging to reach young and new sex workers. What we found in our program is that possibly we are not reaching the sex workers early enough. Though sex workers become positive as they enter sex work, but the program is taking a longer time to reach them. In the Bangalore program, we reduced the time from around 15 months to 6 months, but we find sometimes it's not early enough. Of course, there are issues related to stigma and discrimination against HIV-positive sex workers within the community and from outside. If you see here, again, it's IBBA data from round 1, 2, and 3, we find that HSWs who reported being beaten or raped actually increased through the IBBA data. And also, if you look at by perpetrators, we find that the main regular partner, violence being reported by the main regular partner increased considerably. If you see here, we found that sex workers who have been in sex work for less than 2 years, and which we're categorizing as new sex workers, have quite high HIV prevalence. So though we have been able to increase our reach to young sex workers from 12% to 31%, we still, and when we say young sex workers, we mean below 25, we are still not being able to reach the new sex workers, and I mean, when I say new sex workers, I mean sex workers who have been in sex work less than 2 years. And data shows that they are quite vulnerable and at risk. And these are some of the challenges which actually gave birth to some of our programs in the context of Thrive. And so one of the programs in Thrive that we are trying to implement and address is this whole issue of violence in the context of intimate relationships and low condom use in the context of intimate relationships. This is actually a chart. We did some participatory workshop, and I'm going to talk about it later. And this was a chart that was done by a lover of a sex worker. And I find this chart very interesting because through this chart, we were trying to map out their relationships. And this is one of the few charts where the lover or the man actually mapped the sex worker in the closer circle, showing that his relationship is actually quite intimate, whereas most of the lovers actually mapped and put the sex worker in the last circle. So we started to basically trying and understanding, doing workshops with sex workers and the lovers or the intimate partners to understand what partner violence or risk means in their relationships. So with several participatory workshops we conducted, and what was interesting for us is that this was the first time that we were actually working with men, and we actually thought it was quite successful because for the workshop we invited around 30 men and around 28 turned up, and which was quite a success rate, and that actually gave us a lot of boost that working with men in these communities, especially intimate partner communities, is possible. So we used participatory tools, PRA tools largely, to try and understand what their hopes and fears are, why condom use is so low in these relationships, why violence happens in these relationships. And what was interesting is that the ideal images and expectations of sex workers and intimate partners from the relationship was very, very different. The sex worker was, of course, looking for a man who could father her children, who could take care of her, who could love her, but the intimate partners were largely looking for a woman who could help her at the time of trouble, who could give him money, who could give him different kind of sex, love. But then, even with all those different expectations, there was this whole expectation of trust in those relationships. Love, trust, and intimacy were factors for low condom use. Though a lot of the intimate partners started off the relationship as clients of the sex worker, but when they became intimate partners, they expected loyalty from the sex worker, fidelity from the sex workers. And a lot of the non-condom use is because the intimate partners were convinced that she is no longer doing sex work. Or a lot of violence in the relationship was also because the intimate partner felt that she was going around with some other men. From the sex worker's perspective, there was some kind of a legitimacy of the violence, and she felt, and there was expression that she felt more like a wife if the intimate partner actually beat her up once in a while. So it was clear that there was need to address issues of gender, power. First to understand the issues of gender, power, and then of course to address some of them. So the project that we undertook, we are starting is in Bagalkot and Bijapur districts. These are two districts in North Karnataka, India, and we're talking about covering 2,000 sex workers and their intimate partners. The time frame was for 3 years. This is based on some of the discussions that we've had with Laurie and a lot of evidence that have come in, which says that the interventions are not long enough to measure or evaluate, so it should be long enough. And we're hoping that this is going to become like a pilot project, and we would be able to influence the national program to integrate issues of violence and low condom use in intimate relationships, especially in targeted interventions. So we used the theory of change tool to thrash out some of our understanding, and thanks to Laurie, who actually facilitated workshops to help us collectively gain understanding of the issue and what we want to do. And our problem statement was that despite success in reducing HIV transmission by increasing condom use among sex workers and their clients and decreasing violence against sex workers by clients and police, as shown by a lot of the data I presented earlier, condom use between sex workers and their intimate partners remains low, and violence in these relationships are quite high, and leaving these women vulnerable to STI and HIV. And especially in these contexts, in these geographies where prevalence among men is actually quite high, around 13%. So a theory of change was that KHPT believes that reducing intimate partner violence and increasing condom use in intimate relationships can reduce HIV risk and vulnerability among sex workers. And we believe that, and we propose that we can do this through enhancing self-esteem and self-worth among sex workers through collective and individual critical thinking and reflection process, increasing appreciation of risk among intimate partners, addressing issues of gender norms and power in intimate relationships, improving awareness of rights and laws protecting women against violence, improving the mechanism to provide safety to these women against violence, enhancing intolerance towards violence in the larger community, and partnering with different movements against violence, larger women's movement. We believe that this combination of all this will make the intimate relationship of sex workers safe and violence-free. Of course, our assumptions were that we need to work both with victims and the perpetrators if we're addressing issues of violence, and also larger stakeholders. If sex workers have better skills of negotiation, communication, and access to female condoms, they'll be able to negotiate safe sex better with intimate partners. And action against violence or HIV transmission requires actually a supportive, enabling environment within the larger community where sex workers and the partners live. And this can be done through building capacities of CBOs and linking them up with larger movements. I'm not going to read the impact and the outcomes, but this is what came out through the whole theory of change, a change process. And we decided that we need to work at 3 levels, at the sex workers and the intimate partners level, individually and through the group processes, because we've seen collective action group processes have a lot of impact. We need to also work with the larger community where the sex workers and the intimate partners live, and actually build champions who could actually talk against violence, and also at the institutional level. This is how we are proposing that we actually monitor, and some of these are ways to monitor. We're going to be indicators that we're going to be monitoring on, and we are hoping that we should be able to have a good evaluation plan. Look for your feedback, but at this point we are looking at pre and post intervention through a survey method, and we're going to be starting a baseline soon, and then do an end line by the end of third year. We're trying to also see if we can actually have a control district where these interventions are not going on, and also do a survey there to compare. We will be also doing a pre and post evaluation of these group sessions that happen to see to measure the levels of self and collective efficacy and beliefs around violence. And there would be also an element of qualitative research, especially trying to understand what these relationships mean for both men and women, and expectations from these relationships, especially focusing on the men. Okay, here are lots of people to thank. Sex workers, to start from, all my years of working with them. My Sankalp team, my team in India, a lot of co-directors who have contributed to my understanding and our program, and of course I had this wonderful program team who would implement some of the ideas that we all had. More recently, the Strive team for actually introducing us to the theory of change and actually facilitating 2 workshops with us to develop some of these thoughts. And of course, the donors and funders without whom it's difficult to implement programs.
One thing I realized is you were using a couple of terms that I'm not sure that everyone was familiar with. You were talking about the IBBA and the polling and the various different ways that you collected data. Could you just walk us through those 3 different sources of data that were collected so that people are sort of clear on the different types of data that you had in the original monitoring of the Avahan project?
Sure. The original monitoring of the Avahan project had 2 methods. One was the IBBA, which is the Integrated Biological and Behavioral Assessment, and the polling booth surveys. Polling booth surveys is actually more indigenous to Karnataka. It was not part of the design of the bigger Avahan program, but IBBA was part of the bigger Avahan program. IBBA is basically a large-scale survey. Where I think till now we have got around more than 6,000 respondents. Every round has around 2,000 plus respondents. And of course, random sampling and all of that. And besides administering a behavioral survey tool, we also collect blood for biological testing. It is done in the project of 10 years. Its duration. It's done 3 times, so it's done every 3 years or so. Polling booth, however, is basic. We do it in Karnataka more to look at so it's annual outcome studies, and looks at 3 or 4 behavioral outcomes. Mostly, one is condom use, one is knowledge, one is violence largely. And these are very simple surveys which are done through a yes/no question. We create a booth-like environment, and where women have yes and no cards, and we ask a question, and the answer would be yes or no. Did you use, for example, condom with your regular partner in your last sex act? It will be yes or no. And they put a card in the box, and finally all the yeses are counted and the no's are counted. The answer is not linked with individual, but with the group as such. It's very quick and simple and dirty. So we used it for annual outcomes. Every year we would do it. However, through the IBBA and the PBS study, we realized when we, as a program, Avahan realized as the program progressed that a lot of the indicators related to mobilization, self-esteem, collective efficacy, all of collectivization, all of that is not being collected through these studies. So 2 years back, they started another survey, which is called a behavior tracking survey, where they had a lot of these questions, and they are just starting the second round of behavior tracking surveys. And some of the data that comes about membership in collectives versus condom use and visit to clinic, all of that comes from the behavior tracking surveys.
Great. Okay, so I have 3 people in line, Lifa Sanudi, Sipa Nono, and Anna Forbes. So Lifa writes to us, she asks, what did you find as the cause of violence between the intimate partners? So did you want to offer some reflections on that? I'm sure you're not quite to the level of knowing the cause yet, because it's a complicated thing, but do you have some observations from what you've heard from the women and how they understand the violence?
Sure. So, I'm going to share some of the response that came from the participatory workshops that we did with both men and women. And from the woman's perspective, very interestingly, the cause of violence is largely because if the intimate partner is suspicious, she's having other relationship. So what was very interesting for me is the intimate partner gets into this relationship with a sex worker knowing very well she's a sex worker, but he does expect some kind of fidelity from her. He does expect that she is loyal to him. And a lot of the violence, and sometimes it can be very bad physical violence, like even trying to put the woman's hand into hot oil and things like that, is because of the suspicion that she is going around, she has a different relationship, she is still doing sex work. And that's the response that came from the woman. Of course, the other reasons are more and these are like more actually precipitating factors, really speaking. I'm sure there are other underground reasons, but things like not listening to the partner, or if she's too demanding. If she's demanding for his time, he would actually be violent. From the man's perspective, it is again this whole fidelity and loyalty and all of that. Plus, very interestingly, he says he uses violence because he finds managing 2 relationships sometimes very stressful. So the stress makes him beat her up or whatever. As I said, these are like, as I said, precipitating factors. There are much more issues of gender and power and this whole legitimacy and things like that, which causes violence. Great.
So we also have a comment from Sipanono, who wanted to know how long a little bit more about the training of the peer educators. So what type of training did they receive? How were they supported as they moved into their role of outreach workers?
Just to explain the kind of outreach structure that we have, we have for every 50 peers, 50 sex workers, around 50 to 60 sex workers, we have one peer educator. And the peer educator is either selected by the organization or in many cases also selected by the sex workers for their sites and for their geography. And the responsibility of the peer is to ensure that she is available during the good times and bad times of these 50 to 60 sex workers. She is responsible for the health of the 56 sex workers. She is responsible making sure that none of these women get STIs or HIV, and if they have any experience of violence or whatever, she's there to support them. So she kind of becomes the person responsible for the 50 to 60 sex workers. And then each peer, almost 4 to 5 peer educators are supported by an outreach worker. Now, the outreach worker initially in our program were non-community people, but eventually the peer educators got promoted as outreach workers, and today we have outreach workers. Most outreach workers are community members, and we have program managers who are sex workers. The training is actually quite long drawn. It's in kind of a modular training. So we don't give training in first go. In some of the places I have seen, there's a training module of 5 days, and then there's no training for the whole year. But we do trainings for 3 days, and it depends on different topics. And then we keep funds for training for emerging issues. So that when we first initially planned, we didn't think we will have trainings on entitlements and rights and things like that. But we had to have, because people, sex workers wanted it. We didn't know that we would have to have training for the sex workers to actually go to the police station and see how the case is filed and everything, but we had to include it as they wanted it. So I would say on an average there is around 20 days of formal training for peer educators almost every year, but there is also other forums where every 15 days the peer educators, outreach workers, and the coordinators meet together, and there is sharing that happens, there is informal training that happens.
Great. Okay, so Anna Forbes, do you want to unmute yourself and ask your question?
Yes, I think I'm unmuted. Can you hear me?
Yes, we can.
Okay, thank you. Very interesting presentation. Thank you very much. I'm afraid I missed the first 2 minutes of it because it's extremely early in the U.S. where I am. But I wanted to ask, did you base the design of this program or draw from other programs like this that are being done in other countries at all, or was this something that you designed kind of from whole cloth based on what's happening in your area?
Thanks, Anna. I think one of our principles has been that let's not reinvent the wheel. So I think a lot of the things that we are doing in this project, I don't think it's homegrown. We have did literature search, we talked to people, we looked at some of the successes and failures of such programs that have happened with intimate partners, and adapted it for the local needs. In the context of violence, we know the Image Project had a curriculum called Sisters of Life, and then there is data from South Africa, Rachel Juke's work on stepping stones, and our own work shows that groups work, and a group reflection process and participatory processes in groups work to protect people against violence. So we looked at those concepts and we borrowed those concepts, and we have developed and adapted our own curriculum, which is more local to the women's needs. So I don't think this is very homegrown. The needs are homegrown, but we have looked at various different models and look at literature review. Again, there is this whole, we have a counseling element, and there's a mixed literature on counseling, whether counseling would work or not. But when we consulted with our woman felt that there needs to be a space where she can go for catharsis. She can take her partner, and she wanted that space. So we have added that counseling component, and we will evaluate over a period of time whether it really works in our context or not. Maybe it works, maybe it does not. We're not sure, but so I said this is not. I don't think these are all original concepts at all. I think these are borrowed but adapted for local needs.
Thank you very much.
In consultation with the community. Thanks, Anna.
We have an additional question, which is, how did you go about identifying the sex workers who were involved? And the question comes from a colleague who works in a setting where sex work is criminalized and women are not as ready, perhaps, to self-identify as sex workers. And did you find the challenge of finding the women to engage at all a problem in your setting?
Sure, I think that's a good question. Sex work is also illegal in India. There are different kinds of sex work. There is brothel-based sex work, which is not in Karnataka, but it is there in Mumbai and West Bengal, Sonagachi. And in those, of course, in those contexts, sex workers are easy to identify. But in our context in Karnataka, it's mostly street-based sex workers and home-based sex workers. And home-based sex workers are very difficult to identify. So for us, we were depending on our peers. For us, two or three things actually worked very well. One thing is, though our mapping data initially showed that we have X number of sex workers, we were in a fix. How do you go and find these sex workers? But when we started making visits to these streets, when we started making visits to the sites which the mapping data had identified, we did find one or two sex workers who was quite identifiable. I mean, she's a street-based sex worker. She's kind of dependent on sex work, and she has lost all inhibition, and she is willing to be identified. So we identified one or two of those sex workers, and then through a snowballing process, tried and identified other sex workers. It wasn't a very fast process, but we then identified peers who are willing to take leadership, who are willing to help us in our project, and through them. The other thing that worked in our context is that we found that once we start addressing the sex workers' needs, more sex workers come in. So in our initial discussion with the sex workers, they wanted a space of their own. They said, I must say the initial discussions with sex workers who were on streets, because home-based sex workers we couldn't identify. And when we said, what do you need? I mean, we can give you STI treatment, we can give you condoms. But they said, no, we want a space. We're in the sun the whole day. We are standing around in the afternoon. We don't get any clients, but we don't even have a place to wash our face or even to go to a toilet. The public toilets are filthy and dirty. And we started these drop-in centers, and we asked them, where do you want these spaces? And they said, near the bus stand or near wherever. And we started these drop-in centers where they could just come and relax. So one sex worker started benefiting out of it. She started calling her friends. And then from there, more friends and more friends. And then when the clinics started, they started getting free service in these clinics. And the last nail was when we started actually addressing the issues of violence. When they came to know that this organization or this group of people, they actually care for us, they can address our needs. Whenever there's a crisis, I can go to them. I think we got even more and more sex workers coming in and joining the program.
Great. We have a methodological question from a colleague here at the London School, Colum Davey, and he wants to know why, in evaluating the violence intervention, you didn't choose to use a cluster randomized trial, or at least finding comparison sites. Now, I believe that actually you do have a comparison site. So could you speak a little bit to how you chose or thought through the evaluation design?
Okay. Hi, Catherine. I believe I have come all the way from India to Nairobi to work with you a little more closer and to understand some of these methods better. Why we didn't start an RCT, I think it was more of a methodological issue that I guess Avahan would be able to answer. There were initial lot of debates about, because we were doing this study in the context of a funding and a program. There were a lot of debates initially in the Avahan program itself about RCT and IDBA, and the funder took a decision for the reasons of their own, to actually do IDBA, and we do get flack from time to time about not using RCT. But in this project, which is a much smaller project, and we have tried funding, we're actually talking about having our comparison site. We're talking about doing this survey in another district, which is, of course, have close characteristics with Bagalkot and Bijapur, where we are doing the intervention, and doing the survey in that district as a control district or a comparison district, and see where we get from there. So it has, but ideas on evaluation are most welcome, because we want to generate good body of evidence in an area which is less researched.
I'll just add to that, and it would be interesting, Colum, if you wanted to respond by hitting *7. I think this is an area of intervention work which is highly underdeveloped. There's almost no projects that exist that have attempted to take on the issue of violence within long-term partners or intimate partners of sex workers. So it's also a question of how complicated and how much money is it worth in terms of investing in evaluation in a very early sort of formative part of trying to figure out what to do. So in the discussions, we felt, since there's hopefully going to be a great deal of lessons learned about what seems to work or not work around the intervention itself, that the first step would be more modest before we would actually invest a larger amount of energy and time in scaling up both the intervention and the evaluation strategy. So I don't know if, Colum, you want to say anything. Otherwise, we have one final question. Okay, so let's go on to the final question, which is from Bella Huang. And she says, when starting up and developing a new sex worker program, what are some of the most important areas to address first in designing a program like this? So I guess in terms of where do you start?
Today I feel that I think the design is kind of quite standard. I don't think we have to rediscover things, and I think design is quite standard across the world. There's evidence now that peer education, condom promotion, STI treatment, community mobilization works in HIV prevention, and I think that should be those should be the elements of a program. But I think one of the key things, and that's personally for me, I think is, besides all this theory, is for a new program, I think what is most essential is to build the trust of the community, trust of the sex workers. If you can't build their trust, I think doing a very beautiful and good design program wouldn't work. And I personally feel how we build the trust is for a program to offer what they need the most, not what the funder or we think would be an ideal program. So for our funder and for us, we knew the ideal program is a condom promotion and a STI program. But I think if we wouldn't have addressed issues of violence, if we hadn't addressed issues of stigma around being a sex worker, if we had not addressed the issue of a collective identity, I think we wouldn't have been successful. So for me, I think building that trust and consulting the community and addressing what is their need, I think is quite essential for a new program.